Hello, I'm Patrick Fisher, President of Orthofix Limb Reconstruction. Welcome to our Fitbone Transport and Lengthening System virtual launch event. We're excited to introduce the latest innovation from Orthofix and the only intramedullary nail designed to transport or lengthen bone through a single surgery. The Fitbone Transport and Lengthening System, engineered with our motorized technology, which has more than 20 years of clinical use, is an all-in-one internal solution that allows surgeons to treat segmental bone defects seamlessly. At Orthofix, we strive to be the leader in limb reconstruction. It is our top priority to continue to innovate, allowing us to provide simplified solutions for traumatologists, ortho-oncologists, and limb reconstruction surgeons. After being in a limited market release for the last year with very positive feedback from our surgeon users, we are excited to commercially launch the Fitbone TLN system to the U.S. market. Now, allow me to introduce our surgeon faculty and early adopters of the Fitbone TLN system, Dr. David Fromberg, Dr. Brett Christ, and Dr. James Blair. Our surgeon faculty today will be sharing their experiences with the Fitbone TLN nail, challenges they've overcome, and sharing their wisdom on how to prepare for future cases. Now let's hear from Dr. Fromberg.
Thank you, Patrick. Hi, I'm Dr. David Fromberg, an orthopedic surgeon specializing in limb reconstruction in New Haven, Connecticut. I'm so excited to be here with you all for this virtual launch event. Let's talk about the Fitbone Transport and Lengthening Nail, or TLN for short. This system is FDA cleared for treating both segmental bone defects or limb length discrepancies in the femur or tibia using a single intramedullary device. That's something that caught my attention early on. Traditionally, managing large bone defects in a limb length discrepancy required multiple stages of external fixation. The Fitbone TLN system offers an internal approach with motorized transport and lengthening capabilities, no external frames involved. One feature I want to call attention to is what's known as the rewind and go technique. This technique allows surgeons to address defects up to 120 millimeters by performing a partial transport, rewinding the distraction rod, and then continuing the transport process, all without exchanging the implant. In the right case, this provides significant flexibility and extends the treatable defect length beyond a single transport pass. That can be a valuable option in certain complex reconstruction cases, like after trauma, infection, or tumor resection. The Fitbone TLN system may be especially useful for orthopedic trauma surgeons, limb reconstruction specialists, and orthopedic oncologists who are managing diaphyseal bone loss and need a tool that integrates both transport and lengthening in one single system. Of course, proper patient selection and pre-op planning are critical, as with any complex reconstruction, but what this system brings is another tool in the toolbox. It's not a one-size-fits-all solution, but it does give surgeons a new intramedullary option for challenging cases. And in the limb reconstruction space, having more treatment flexibility can make a real difference when planning these complex procedures. Before I hand things over to the next presenters, I just want to take a moment to reassure everyone that both I and the Orthofix team are here to support you every step of the way. I highly encourage you to take full advantage of the training opportunities available, and don't hesitate to reach out to colleagues who've already completed a few cases. That kind of peer-to-peer connection is invaluable for picking up tips, troubleshooting early questions, and building confidence with this system. It's also important to make sure your sales reps are well-versed in the Fitbone Transport and Lengthening system. When they understand the clinical workflow, they can be a real asset in the room, not just on the logistics, but as true partners in supporting a smooth case. Next, let's hear from Dr. James Blair and Dr. Brett Christ about their early experiences with the Fitbone Transport and Lengthening system.
So a case I'd like to demonstrate is a 41-year-old male who sustained a low-velocity gunshot wound to his distal tibia and had some significant segmental bone loss as well as soft tissue loss. He underwent free tissue transfer as well as intramedullary nailing with a cement spacer and eventually underwent bone grafting approximately 8 to 10 weeks afterwards. Unfortunately, the bone graft did not take very well, and he continued to have pain at his defect site with very poor bone that had been bridging through the gaps. And he had been dealing with this for about 2 to 2.5 years before he saw me in clinic. When I evaluated him, luckily there was no concern for infection, and he was a relatively young and healthy individual. And I gave him multiple options as far as repeat bone grafting, exchange nailing, or resecting the bone and performing a bone transport, which he was very interested in doing. I gave him multiple options as far as circular fixation, as far as plate-assisted bone segment transport. But again, I thought that he was an ideal candidate for a bone transport nail. And so when we took him to the operating room and we resected out some of the unhealthy bone that he had about a 10 centimeter defect. We gave him a 10-day latency and we transported him at 0.66 millimeters per day, and his regenerate looked great. I offered to him the potential of speeding up, but he wanted to just stay the course, and I thought that that was very reasonable. Once we had maxed out the stroke length, we did go back to the operating room to do a rewind. We opened up the slot, we opened up the skin of the slot, which was right around his flap, which at this point had matured and had looked great. We stabilized the transporting segment with a small 2-pin external fixator, and we rewound the nail so that the transporting slot could be much more proximal. At that point, now we could get an interlocking screw into the transporting segment, and at that point, he continued on his transport until he docked. We took him back to the operating room right as he docked and performed a standard docking site procedure, which involved opening up the docking site, debriding out all the scar tissue that had formed, freshening up some of the bone ends, and applying compression through the nail and maintaining that compression with a small plate. We then did his exchange nail at that time, and we removed the Fitbone nail and placed a standard trauma nail. I let his regenerate mature for about another 4 to 6 weeks before I let him weight bear. And at this point in time, he is now weight bearing as tolerated. He is back in the gym as a fitness instructor, and he is very happy. He essentially has very minimal pain that I think will only continue to improve as his regenerate matures and his docking site continues to consolidate. Another case I'd like to discuss is a 27-year-old male who sustained a low velocity gunshot wound to his distal tibia, and he presented directly to our hospital with this injury. I took him back to the operating room that day to do his initial debridement and irrigation, and he had some significant bone loss to the point that I considered him to be a critical size segmental bone defect. Luckily, he did not need any free tissue transfer, and we were able to get his traumatic wounds closed primarily. But we placed him into a temporary external fixator, and we had a very lengthy conversation about what his treatment options were. I did not feel as though a induced membrane and bone grafting or a masculate technique would be as consistent, especially in the traumatically injured distal tibia for him, with a defect size that was approximately 85 millimeters. And so when we discussed potentially performing bone transport with a circular external fixator or an all-internal technique, he elected for an all-internal technique. And I felt as though I could trust that he would be able to abide by the weight-bearing restrictions. And so in this case, we had enough distal bone stock that I thought that we could reliably get our interlocking screws. We had a very lengthy preoperative planning session in which we planned out the specific nails and the nail lengths that we would need. And again, I knew that we would need to do a rewind at some point in time. When we did his preoperative plan, luckily the transporting slot did align with his intact bone. So we were able to use a simple transporting screw in the slot for the entirety of his transport. He also got a 10-day latency period when we performed this and a transport rate of about 0.66 millimeters per day. Once we had maxed out the transporting slot, we did have to take him back for a rewind, which was very easily done with a 2-pin external fixator to stabilize the transporting segment. We removed the transporting interlocking screw, rewound the nail, and then inserted the screw again. Based on our preoperative plan, we knew that with our corticotomy being as far away from the defect as possible, we weren't worried about running out of bone stock for our new interlocking screw because we had planned this out already. His transport continued that same day, and once he was about to dock, we took him back to the operating room to perform a docking site procedure, which involved opening up his docking site, cleaning out his scar tissue, making sure that his bone ends were nice and fresh and healthy and viable. We compressed his docking site, It was stabilized and we removed the transport nail at that time, and this was exchanged with a standard trauma nail. I did want to keep him non-weight bearing for about additional 6 weeks. And at this point in time, his regenerate continues to mature. He is just starting to be weight bearing as tolerated at this point in time. He's getting around just with a single crutch and says that he's feeling better day by day. His x-rays at his most recent follow-up are starting to show some consolidation in bridging cortex at the docking site with continued maturation of his regenerate.
Regarding specific cases that I've used the transport nail or transport plus lengthening nail, they have all been femur cases, and they have very similar kind of patterns. Basically, they've been recalcitrant femur non-unions, mostly in larger patients. Pretty much all of them have been larger patients, and they've all had at least 3 or 4 attempts at trying to get union. And they've had pre-existing deformity. So they've had treated with nails, they've presented with nails in place. One of them has been mine, or actually 2 of them have been mine that I've gotten healed, and then she wanted lengthening. So then I did it again, and then she got a non-union of her lengthening site. But so they've had some pre-existing deformity with or without implants in place. And then kind of the one that is, I would say, that has had the most surgeries, or I'd say the most difficult problem, because they also have pretty bad knee arthritis, is a male in his late 30s that got injured in a motorcycle or motorbike accident in a foreign country and had worked there and got treated there, and then has had basically a 6 centimeter defect with a distal femur non-union and a knee flexion contracture. And so at the time he presented, there wasn't a transport nail available, and so I did a staged plate-assisted bone segment transport technique. Like I had mentioned about how it's nice with the nail that you can have the anatomical axis protected, so the transport segment or the limb doesn't fall into varus or valgus because of lack of the opposite column stability. And so he had a big enough defect that he fell into varus through his regenerate. And so when the Fitbone lengthening nail became available, the plan was, because his distal femur still wasn't healed, was to correct his alignment, gain another 1 to 2 centimeters of transport, and then also continuously compress the docking site after grafting it. And so he has gone on to, he is 6 months out now. I haven't seen him for about 2 months, but he was starting to form union at his docking site, and his overall limb alignment had significantly improved, and his regenerate was forming proximally too. These were all good candidates because they had other forms of non-union treatment that didn't work. And I think I could have done, I have vowed never to put a circular frame for transport on a femur again. That's not a very fun situation for the surgeon or particularly the patient because of obvious inconvenience with the size of the frame and being able to even get on the toilet. So that's a big problem. But they're also, they're obese patients, and so trying to do a cable transport in somebody who has a high risk of having a soft tissue infection is also not ideal. And I think the experience that I've had with plate-assisted bone segment transport in the femur and the resultant deformity kind of also painted, or I guess made me want to use a transport nail.
So for my limb reconstruction practice, I have patients who are acute traumas and have, high energy, fairly devastating injuries. And then I also have patients that are referred to me either with these high energy injuries or a lot of times with post-injury infection, and times they're missing a lot of bone or soft tissue. And so I think both of those patients are types that I'll be treating.
So far, I've only used the femoral nail, and it's been in people who've had really difficult femur healing problems, multiple surgeries, sizable defects, previous non-union attempts. So having the Fitbone nail, transport nail available allows for, I think, convenience for the patient. They don't have to worry about pin site care and the concern for pin site infections. And they use a simple, relatively simple process of adjusting the implant. For the surgeon, it's the same thing. I don't like to say convenience, but it's less intrusive for the patient and the surgeon because they don't have to deal with the pins. And then also it's transporting along the anatomical axis, so you don't have to have the same concern as with plate-assisted bone segment transport or with X-fix only transport, where you can have drift of the transport segment to where your overall alignment or the alignment of the segment changes to where they may not be able to get some procedure down the road or making it more difficult. And then I think the third thing is just having a nail instead of independent pieces with frames. I think the nail adds stability and strength as well for longevity of the implant.
So going into my first Fitbone TLN case, I wish I had known that these nails are delicate. These are not trauma nails that you can just pound out with the mallet. They need to be taken into, the internal mechanics need to be taken into consideration. And so this is a very gentle finesse surgery that needs to go slowly. And there's a lot of different ways that we can plan this out. But all of the different types of bone paths and ball tip guide wire, all the different little tricks and things like that, that all gets magnified when you're not really able to mallet out the implant because it just needs to slide in. That's probably the biggest thing for me. Post-operatively, there wasn't much that I wish I had done differently. I had some experience with the transport nails prior to doing the cases with Fitbone, and I know that you just need to go slow with the transport. I think that myself included, we all just want to go fast with the transport, but ultimately the corticotomy gets reamed, and I think that there is a biologic insult that happens to this, which is occurs for every case. And so with that being said, I think we just need to go slow with that. And again, having the patient compliance of understanding that these are not regular trauma nails that you can weight bear on. And so, understanding those indications and having the right patient selection is incredibly important. As far as tips and tricks goes, I'm still getting used to understanding how the receiver and the cord goes, because that is a little bit different, and that is a very specific nuance to this nail. Once I sort of understood it, it wasn't really an issue. But to me, understanding that you need to have a good subcutaneous pocket to make that receiver nice and stable. I did have a case in which that receiver got dislodged during the patient's transport. We were able to identify the issue, and I think it was a technical error on my part. But understanding that, I think, is one of the bigger nuances that I picked up on since starting and doing these nails.
I think the tricks that have optimized for the actual surgery has been basically doing more than one. So I think anytime you do something new, I think it's easy to get, it's not just with this, but it's easy to get frustrated if it's not going exactly how you think it should go. And so I think people need to be patient in doing anything new, not just Fitbone, but any kind of new implant. You have to be willing to take feedback and think about kind of how it went and improve. But I think for me, it's been mostly just efficiency. So understanding or getting more familiar with the system has just made it go smoother and go more efficiently.
Pre-op planning is critical to me because there are so many different nuances with the nails themselves based on length, based on stroke length, and based on where that slot exists. And so having very good calibrated x-rays allows me to understand exactly where the slot will lie in relation to the defect and where the interlocking transport screw will be, how long the nail needs to be. And so having a good idea will allow my reps to have different options for nails available, but also just lets me understand what the surgery itself is going to look like. These are complex cases that don't necessarily go quickly. And I think that the more planning that you can do beforehand is crucial. The last thing that I want to do is get into the middle of the operating room and have this whole case, proceed on, and then realize that the plan that I had is not going to work and I don't really have a backup. I don't ever want to get into that situation, and pre-op planning is critical to prevent that from happening. Pre-operative planning allows me to counsel the patient, to have them understand what they can expect. It allows me to understand a little bit more of what I can expect going through as I follow these patients in clinic. And again, whatever makes my life a little bit easier in the operating room, I'm trying to do. And so having a good preoperative plan will decrease my anxiety level a little bit as we go through some of these cases that are, again, let's admit, are fairly complex. And so it allows me to understand potential pitfalls and, again, plan out future surgeries that I think that the patient may need based on their injury characteristics. Some of the most common planning mistakes, and again, they may not necessarily be mistakes, is just thinking that the transport slot will be in a very specific spot where the defects, in relation to the defect. And sometimes we get into the operating room and realize that the edges of the bone need to be cleaned up a little bit, and maybe the defect is a little bit bigger. And so now we need to switch gears a little bit, and maybe we got to change the length of the nail or have a different stroke length so that the slot can end up in a different spot. That's definitely been something that I've seen in my own practice in doing these nails. And again, sometimes there's only so much planning you can do until you finally just get into the operating room and just execute.
Do I use blocking screws? I'll use them if indicated, or at least if I don't feel like I can get a blocking screw to allow for the nail to go through, it'd be a blocking drill bit or wire. But yes, I think alignment's critical. So I will use blocking screws if it's usually in the metaphyseal region distally or proximally. Sometimes it's in a larger diaphysis, but basically most commonly it would be to, I would say, correct varus proximally in the subtrochanteric region for an antegrade nail, and then distally it could be either varus or valgus, but a lot of times it's you're correcting valgus.
So when using a transport nail, whether it's in the tibia or the femur, I will always use blocking screws. And the reason is because I initially did not use blocking screws, even though colleagues and mentors told me that I should. But again, I had a young, healthy 23-year-old patient. And again, these are not standard trauma nails. There is a lot of micromotion that happens. And I think that inevitably there is some fixation that is lost in the interlocking screws just by the nature of having mechanical gears and an actual transport occurring during the nail. And so I think that we just need to be cognizant that there may be some loss of fixation in the interlocking screws. So to me, just from my own experience and having a little bit of loss of reduction without blocking screws in the tibia, especially proximally, I will place medial and lateral blocking screws around the nail. And I'll also place a posterior blocking screw to prevent a procurvatum deformity. Distally, if I have the osseous real estate, I will usually place 1 or 2 blocking screws just to make sure that there's no loss of fixation. Now again, because in my practice, I will do the exchange nail as soon as the docking site, or as soon as the transporting segment docks, inevitably I can change any malreduction that does happen, but I'd like to just prevent this in the first place with blocking screws. In the femur, it's the same concern. I'll place blocking screws to prevent a varus and procurvatum deformity that will inevitably happen in the proximal femur, and then I will usually place medial and lateral blocking screws in the distal femur as well.
My standard latency for the femur is it's not that different from the tibia. For me, it's usually between 10 and 14 days. Usually for the femur, if it's been a really recalcitrant non-union, I'd probably go 0.5 millimeter a day. If it's more of a healthier patient, or if there are patient factors like comorbidities that make them delayed healers, I'd probably go 0.5 millimeter a day, but most of the time it's 1 millimeter a day for the femur. I'm more likely to only do 0.5 millimeter a day for the tibia, especially for larger defects that are going to take a while anyway.
So for the tibia, I know that there is a biologic insult from performing the corticotomy in and of itself, as well as reaming through the corticotomy just by the nature of inserting an intramedullary nail. So to me, I typically will do about a 10-day latency. And for my transports, I like to start off a little bit slow and then speed up when I need to. And so for me, this is about 0.66 to 0.75 millimeters per day, depending on the age and health of the patient, and then speed up from there. And so 10-day latency, about 0.66 millimeters broken up throughout the day is my preference for a latency and a rate rhythm. In the femur, I think we can be a little bit more aggressive, typically because the biology to the femur is a little bit better. But still, there's a biologic insult from the corticotomy itself, as well as reaming through the corticotomy just by the nature of inserting the nail. So I will typically do a slightly lower latency period, usually about 7 days, but I still have about a 0.66 to 0.75 millimeter per day transport rate just until I can see some regenerate forming, and then I usually will speed up from there. I'm typically not worried about a premature consolidation when using a transport nail, just because I know that the regenerate is a little bit slower than other ways of performing bone transport, specifically with the circular external fixator. So with the rewind technique, let's say, for example, you had a 10 centimeter defect, but only an 8 centimeter stroke length in your nail. So in the nail here, this is your transport interlocking screw, and this would come all the way down to the bottom. But if you still had some transport that you had left to go, you would need to come back to the operating room, stabilize the transporting segment, remove the interlocking screw, and then you would actually rewind the nail intraoperatively to get the screw hole back to the top of the slot, and then you would reinsert your interlocking screw, remove any temporary fixation of the transporting slot so that you could continue the transport back down. During the rewind, there is a theoretical concern that if you remove all the fixation from the transporting segment, that the immature regenerate will cause the transporting segment to rebound and spring back a little bit, and that would cause you to lose some of your length that you've achieved in your transport. So I typically like to place a small 2-pin external fixator that I place under fluoroscopy, usually with 4 millimeter half pins, and just something to keep the transporting segment where it needs to be. And at that point in time, I feel comfortable then removing the interlocking screw. And under fluoroscopy, I will actually watch the transporting slot move back as we are rewinding it with the receiver. You do need to make an incision to retrieve the receiver, and I typically will hold it in my hand. Another little tip that I've sort of learned from doing this is that there's a very specific way that you need to hold the receiver and hold the transmitter during the operation. It can take anywhere from 15 to 20 minutes depending on how much you're going to rewind. But again, I like to keep the C-arm in the same exact spot, usually in the lateral position, so that I can watch the interlocking screw hole retract. And we'll do this again over the course of about 15 to 20 minutes is usually what it takes. And then once I've achieved where I want that to be, it's very easy to then just put the interlocking screw back in with a new drill hole. And at that point in time, tuck the receiver back into its little pouch, and then we're done. It typically doesn't take very long. And we then will test the nail one more time just to make sure that everything is working. And the patient continues on the transport that very same day. During the rewind and go, I don't really see a need that we need to introduce a latency period. We're just continuing the transport as usual. And so, no, I typically will tell the patient, transport and use your remote whenever you normally would. If your case is going to be later in the day or if it's in the morning, I have no issues with them continuing on their transport. So there's no reason to slow down. And again, it's another selling point to the patient to let them know that even though we're going back to the operating room, it's not costing us any time. This is expected. This is anticipated. This is just what we need to do in order to continue the transport. And again, it's usually for these larger defects that we're doing this for.
So the standard docking site protocol for me would be to, cut a flat surface for the area that you're trying to dock the segment to. I will sometimes use Stimulan in those cases while we're starting the transport, just if they've had a particularly resistant organism previously. So that would be a time where there'd be temporary antibiotic beads. And then as they're getting to be within about a centimeter or between a half to a centimeter left of transport, I'll go back, and usually lately what I've been doing is using bone marrow aspirate with a bioglass product. So as far as whether or not I take them always back for grafting the docking site, I guess one exception would maybe be like a teenager that's super healthy. That would be one exception previously, that with a frame, I didn't do that, but I would say I can't think of anybody else that I haven't done that. And then also really compress, so then dock and then continue to compress at least 3 millimeters as long as the implants aren't showing stress, essentially. So it would be basically like getting to the point where I think they're going to finish docking and have them come back to clinic, and then make sure that there's nothing weird on the x-ray, or that the implants aren't starting to bend, and then kind of go between 2 to 3 and check them back again in 2 weeks, and maybe like 2 to 3 weeks, just to see kind of what it's showing. And then if there's not, say like in 2 months, there's not really anything forming, then I would be able to get the box that we can reverse the transport to basically distract and then compress again. So distract for a couple of weeks, compress again, over compress, and do that maybe 2 times depending on the specific situation.
In my practice, I would say that I typically perform a docking site procedure every time. I think that the only time that I would consider not doing it is if I had a very short transport. And by short, I mean maybe 3 or 4 centimeters. If that's all I'm transporting, then I'm not as concerned about scar tissue developing, because I know that this won't take that long. But even then, I think I would still be inclined to do a docking site procedure. And by docking site procedure, I mean, I will, when I'm doing my exchange nail, I will take the patient back to the operating room. I will open up where the 2 bones are coming together, and I will clean up as much of the scar tissue that I can. And I will make sure that the bone ends look healthy and viable, and I will continue to compress the docking site as much as I can. I will either do that through the nail if I have enough transport left with the stroke length, or sometimes I'll even take the interlocking screw out, drill some pilot holes, use some large Weber clamps, and I can actually get some compression across the docking site itself. I always will stabilize the docking site, and that can be either with a small mini fragment plate or an extra interlocking screw hole that I will manually drill through the trauma nail. But I typically don't wait any amount of time before doing the docking site procedure. In my practice, as soon as I know that the patient is going to dock, I'll take them back to the operating room. Not everybody does that, and I think that that's okay. Some people like to wait a little bit longer. The advantage of waiting a little bit before doing the docking site procedure is that the regenerate will mature a little bit more and will have less chance of recoiling and rebounding. But to me, I think that the risk is that you may not necessarily get any more compression through it if the regenerate is too mature. So to me, it's an easier sell to the patient saying, hey, look, you're 4 or 5 millimeters away from docking. Let's get your docking site procedure scheduled for next week or the week after. And it just gives them something to look forward to in this very long process that typically tends to be.
So my post-docking protocol currently would be limited or foot flat weight bearing until there's regenerate that's pretty solid, not definitively solid, but at least showing up throughout the entire regenerate zone. And then once that is starting to be kind of confluent, then I would let that, as long as they're, they can put pressure in clinic and it doesn't bother them, then I would let them start transitioning off an assisted device.
Post-operatively, after they've done the docking procedure, I think that they could weight bear pretty soon, but for me, I usually keep them off for about 4 to 6 weeks so that I can let the regenerate mature a little bit. And for any non-neuropathic patient that can self-limit at about the 4 to 6 week mark, I'm usually okay with them weight bearing as tolerated at that point.
Okay, what makes the Fitbone transport nail unique versus the competition? I would say the previous companies that I had used for the transport system, basically every one that I did, the transport slot eventually fatigued and broke. And I think part of it is because it's thinner than this. And so I think that would be one unique component of it. And the last thing that I think it differs from the other systems available would be the ability to lengthen as well as transport. Once the transport is finished, then depending on the specific nail, it can lengthen a specific amount afterwards. So it could mean less surgeries in the end for the patient.
So specifically with the Fitbone nail, I think that there are a couple advantages to other bone transport nails that may be on the market. And number one, I think that there is a little bit more reliability with the interface between the remote control and the receiver. I think just the fact that the patient can palpate the receiver and they know exactly where to put it. And it is a much smaller remote control than other options that are available. Additionally, the fact that there is a transport and lengthening nail is very unique. I know I'm guilty of having patients go through a whole limb reconstruction process only to realize that there is some residual limb length discrepancy that's sometimes difficult to manage. And I think that having an option of performing bone transport and then really keying in the exact limb length that we want, I think is a huge advantage and something that's pretty unique that's on the market today. Having a single slot design just makes some of the preoperative planning a little bit easier, knowing that once we put that interlocking screw in the transporting segment, that we're gonna be able to manage the entire stroke length without having to do any other extra screw exchanges or anything like that. And so I think that there are some advantages. And again, there are some different nuances as far as the slot placement and the sizes and lengths of the nails that, again, make it unique in this market. So for somebody who is doing their first transport nail case, I'd say that the biggest thing to do is really to pre-op plan. These are nails, but they are complex. And I think that for the majority of surgeons, everyone's familiar with intramedullary nailing, but there are some significant nuances that really need to be taken into account prior to doing your first case. So I think that some of the nuances that need to be taken into consideration is where the slot exists in regards to where the bone defect is, how big the defect is, and then understanding the nail schematics, because that slot position can change based on the length of the nail and based on the length of the stroke, or the stroke length that will exist in the nail. And so understanding where that'll all fall together, I think, is very important to understand. It's also important to understand that these nails will only do an antegrade transport, and so that needs to be taken into consideration as well.
I think if they've never done any kind of transport, I think they need to make sure they plan very well. So one of the nice things with Fitbone is that you do have the opportunity to go over the plan with the representative that's going to be helping you in surgery to make sure that there's a lot of detailed planning going on to make sure that everything's going to be where it's supposed to be and have a good plan going into the surgery. So planning, number one. If you've used other methods, I think they're going to plan anyway. So I think planning is still key. And then I think knowing the specific details of the Fitbone system, because it's not exactly the same as using like a trauma nail to both prepare the bone as well as using the segments or using the parts of the nail that moves the segments. And so that, and then I think patience is the other thing. If you've never done transport before, not only, you know, the person, but like having patience, like you'll want to have this patient up and going right away, and that's just not, or that you want them to heal right away, and you just have to be patient about it and not transport the segment too quickly or not go too slow. You have to be willing to go back to surgery to get the segment moving again. This is with any transport system, because sometimes the bone heals too fast or it doesn't heal, then you have to go back and do another surgery. So I always tell the patients, and I would tell a colleague, that it's a process. It's not a 1 or 2 surgery for sure. It's a process to get this to be successful. And that just amplifies as the bone defect increases in size.
Before sending you off, I'd like to thank our Orthofix team as well as our Fitbone TLN surgeons for their continued collaboration. Although limb reconstruction can present challenging cases to you all, we are confident that the Fitbone Transport and Lengthening system can help simplify these complex cases. We look forward to supporting you as best we can, and thank you for being with us today.